We live?
Yeah.
Okay, great. Good morning and welcome to the Insurance and Pharmaceutical Subcommittee of the Health and Government Operations Committee. Just want to review a few things. We are going to ask everyone to keep their mute button on until they are recognized. For anyone who wishes to speak in our subcommittees, everyone has the opportunity to participate, everyone who's been invited to the meeting. And so use the raise hand function to ask questions. And anyone who is on the Zoom link that was sent out and were invited, most of these folks were participating in the hearing on the bill that we're discussing, and they will be allowed to participate in the discussion. So with that, the agenda for today is that we have two bills, and the first bill that we are going to take up is House Bill 728, Health Insurance Qualified Resident Enrollment Program, Access to Care Act. That's the first bill. The second one is House Bill 240, and we'll say what that is when we get there. So we're going to begin with House Bill 728. Lisa, and there are some amendments for this bill. So Lisa, would you tell us what the bill does?
Sure. House Bill 728 requires the Maryland Health Benefit Exchange to allow qualified residents to purchase qualified health plans on the individual exchange. MHBE is in consultation with the insurance commissioner, and as approved by the exchange board, is required to submit a federal state innovation waiver application by July 1st, 2025 that seeks approval to establish the qualified resident enrollment program and seek, if available, federal pass-through funding resulting from the implementation of the program. If the waiver is approved, the exchange, in consultation with the insurance commissioner and is approved by the board, must establish and implement the program. There are amendments that clarify that the program only allows qualified residents to purchase qualified plans on the individual exchange, clarifies that the state can only seek federal pass-through funds if it is available, and that any future funding for subsidies will require additional authorization by the General Assembly.
Okay. Are there any questions or comments on the amendments?
Move the amendments.
Okay, I have a motion on the amendments. Do I have a second?
Second.
Okay, it's been moved and seconded. Any discussion on the amendments? Seeing no hands. Those in favor of the amendments, please, actually, we should probably go down the line and ask rather than do voice on this. So I'm going to go down the committee. So Bandari on the amendments. Delegate Bandari?
You mean
on the amendments, yes or no?
yes?
Okay. Delegate Gazzoni?
Yes.
Delegate Johnson?
Yes.
Delegate Kaiser?
Yes.
Delegate Kerr?
Yes.
Delegate Kipke?
Yes.
Delegate Morgan?
Yes.
Delegate Schlega?
Yes.
Delegate Tavares?
Yes.
There we go. Delegate Woods?
Yes.
Okay, the amendments pass. Now, do I have a motion on the bill as amended?
Move the bill as amended.
Second.
Okay, I've got a motion and a second. Is there discussion on the bill? Delegate Schlega?
Are there any qualifications as far as how long a person must live in the state to be considered a resident?
No, they're not in this bill.
Because the bill says you have to be a resident. So does that mean someone could move here and be immediately qualified? There's nothing that says you need to live here a certain amount of time.
Okay, I am going to defer to Ms. Fabian Marks. Do you have information on that?
That's correct. There's no time period for residency, which is similar to what we do for current enrollees. We accept their attestation of residency.
So there's an application process. They would have to have they'd have to have an address in the state. But you're right, there is
Yeah.
no time requirement. Delegate Morgan.
Would a PO box qualify them for the application purposes?
Johanna?
I think that we would plan to implement as we do for current enrollees, and I'm not sure of the answer for that for current enrollees, so I can check on that and get back to you.
So I'm going to take that as a yes. That if you had a PO box or even in someone else's physical address, there's no lease requirement or any other type of proof of residency. There's no utility bill or anything like that, correct?
Correct.
No,
I'm sorry, Johanna? No.
yeah, documents are not
Right.
required.
So let me ask you this. What is preventing somebody from living in Northern Virginia that's here illegally from jumping on the Maryland healthcare system?
So we do require the in-state address, and we, on the back end, carriers conduct claims assessment to detect if there are kind of unusual patterns of claims happening out of state.
Okay, but there's no other security metrics in the bill.
And I would suggest that there's no security measure against any U.S. citizen living in North Carolina who wants to buy on our exchange to do exactly what you're saying as well.
Other than they qualify for a North Carolina exchange.
But they may be applying to the Maryland exchange because we're better.
Well, you're dealing with people that live in
Right.
North Carolina here illegally. They're not allowed to buy on the North Carolina exchange. So it's not really an apples to apples comparison.
No, I understand your point, Delegate. I just, but say this bill actually opens up the eligibility to access the exchange to all Maryland residents.
Well,
So, and as
honestly, it
Lucas-
opens up the ability to access the exchange from all residents, period. If we think about it, worldwide, I guess. While I have the floor, though, can I go ahead and ask a question on just availability? Do we have any estimate on how many people that we think might jump on the exchange, and what is the health status of these people?
Johanna, do you want to try that or I can take it?
I can share that we have not looked at that specifically. We, per the legislative study.
Joanna, can you talk louder? I'm having a hard
Sure.
time hearing you.
Absolutely. Is that any better?
Yes.
Little bit.
Okay. I was just saying that per the Senate Bill 806 report that we submitted, we looked at potential enrollment if a state subsidy were to be offered, which isn't the scenario that we're looking at with this bill. We haven't done the analysis of kind of a no subsidy enrollment scenario.
So the answer is we do not have any idea. We are just making it available, and those who are capable of paying the full premium and wanting to have that access would have it. So we just don't know.
But we're going to advertise that it's available. So, we have no restrictions as far as people being on it. What happens? We testify in committee that the nearest estimate is somewhere between 350 to 400,000 undocumented immigrants are here in the state of Maryland, not counting like the Virginia. I'm kind of conscious of this because my county the only thing that separates us is the Potomac River. And I know their illegal immigrant population is significant over in Fairfax and Loudoun County, especially Prince William County. So my question is, what happens if hundreds of thousands of people jump on this on this insurance and tens of thousands of them are sick? We haven't added a single specialist or doctor to handle any of this stuff. And I'm just wondering, we have no way of tracking this and we have no estimates.
Is there someone from an insurance carrier who would have a response to that?
I'd be happy to try to respond, Delegate Morgan. Can you reframe the question? I just want to make sure I'm capturing
What's the estimated people that are going to jump onto the exchange? You're saying that the uninsurance rate is about 5.5%. There's about nearly 400,000 undocumented immigrants. They're calling Maryland their home, plus neighboring areas, which I think would make us susceptible for fraud. How many people do you think will be jumping on the exchange if this legislation is enacted? And of those people that are jumping on the exchange, how many of them do you think are sick or chronically sick?
I think that's a really difficult question to answer. I think that a lot of the barrier for the remaining uninsured is access to care. And I think this bill just gives those folks the ability to buy coverage. I don't know if I can quantify it by the sort of risk score of what the pool would look like. We do know that we want to try to capture as many young and healthy folks as possible, regardless of immigration status. And the more folks that we get onto coverage roles, it should help with the overall risk score. I can't imagine.
Matt, would you agree that past experience has shown us that if we open up a pool to insurance, the first people that are in are generally not young and healthy?
I think that's hard to quantify. I think you're
Really?
relatively on track with that assumption, but I think that it's a little different with this population because they've not had access before, and I think there is a desire to buy coverage, and if so, I would hope that some folks would want to buy coverage so they could protect their family and their peace of mind, just like I think anyone else would buy on the small group market or the large group market if they had access to it. But I don't know that I can give you a solid number on what the risk morbidity score would look like.
So Matt, while I got the floor, I don't want to dominate this subcommittee by any means, but so if let's just say that you're here undocumented and you are having some health issues, what is your option now?
I mean, I think the majority of the population that has no coverage goes to clinics or the ER and gets coverage that way, which is about 10 times more expensive than it would be if you went through a primary care doctor in a covered situation, which I think costs us all a lot less and actually contributes to the bending of the cost curve in a positive direction.
Okay, but we have no information about just how many people that we're expecting this actually could do. And what would be the ramifications for someone that already has health insurance, like a Marylander that's a citizen? If they might have a healthcare need, you have no idea how long this could possibly jam them up from seeking care, correct?
I don't believe, Delegate Morgan, that we have a problem in Maryland finding primary care physicians. I think that
I'm not talking about primary care physician. I was actually concerned about specialists. I mean, my mom recently just had a surgery canceled last week, and she had to go to a cardiologist who's supposed to get a knee replacement, or not a knee replacement, but like a surgery for her knee. And they couldn't do the surgery because her EKG didn't come back. And the closest that she could find an appointment for was May 7th. Not May 7th, March 7th. So look, this has been my personal experience. Every time I needed to see a specialist, it's a 6 to 7 week wait. And I guess my concerns are if we're going to dump tens of thousands of potentially sick people in there, how long are Marylanders, citizens, supposed to wait for healthcare?
So, I think your point is made, Delegate. We're going to move on because I think there's some folks who want to.
Understand. Thank you. Thank you, Madam.
Thank you. Reverend Wilson.
Thank you. I just have two questions. One under qualified resident that says, I think it's number 3, line 12. Is not incarcerated other than incarceration pending disposition of charges. So my question is, how does this impact those who've been detained under our definition of incarceration, including jails, prisons, immigration detention, and juvenile justice facilities? That's the first question. And then the second question is for, according to the Immigration Equality, asylees are entitled to certain public benefits. For the first 7 years after being granted asylum, asylees are eligible for Social Security income, Medicaid, food stamps, and a variety of other benefits and services. I'm just curious if the proposed, if this is proposed, this bill passes, if the Maryland law extends support during the asylum petition process, and could we clarify how this would impact those cases of those individuals who are part of that process if they apply for its benefits?
So I'll answer the second question first, that it would apply from the time that they became a Maryland, that when they are a Maryland resident and beyond. But again, they would be paying full full amounts. In terms of detention, while someone is in detention, while they are actually being detained, they would not be eligible to go through the enrollment process on the exchange. They, have to wait until they were released. Okay. Delegate Tavares.
Thank you, Madam Chair. I'm looking at a report that I basically commissioned with regards to these kinds of issues in my old county. And I just want to highlight the fact that based on my studies of this population in the county, and not just that, but in the state, immigrants are overwhelmingly young, right? The average age is close to 30 years old. So I would beg to differ for the gentleman and Delegate Morgan with regards to his theory that we will have an inundation of individuals that will be overwhelmingly sick. On the contrary, I think that we will have an inundation of individuals that are overwhelmingly healthy and young, which drives cost down. And based on the state's population, it's 15.1% with a growth rate of 9% per year about. And so we are looking, and from there is a strong, like we said, there is 350,000 that are undocumented. And because of that, we're not talking about breaking the bank here. What we do know is that because people are not receiving the very basic care, they wait until the extreme, and they're causing anywhere from 100 to 150 million in cost overruns at the ER. And we don't need that. We don't want that. And so I'll leave it there, but we do need to provide something that is cost effective for this population, because they are making approximately about $50,000 to $50,000 per year as a family unit. But you have to remember that there are multiple family units residing in one home. And so average, from what I was able to capture, at least in my area, we have households that accumulate over $100,000 per year.
Thank you, Delegate. Delegate Johnson.
Thank you, Madam Chair. This question is probably for Lisa. On the previous question about residency, there is a definition of resident in the Tax General Article, Annotated Code of Maryland, and the Code of Maryland Regulations, COMAR, that states a minimum of 6 months. So when we use the term qualified resident, Lisa, would we be bound by that in this bill?
Lisa?
We're bound by the definition in the bill. That's the definition that would apply. We can amend it, but the definition in the bill is what applies to the program, not the other ones that you're referring to.
All right, thank you. Thank you, Madam Chair.
Thank you, Delegate. Robin Elliott?
Yes, so I'm here on behalf of Maryland Community Health System, which is a network of FQHCs, and also do work with the school-based health centers. Just wanted to address what the health centers see as one of the most common scenarios is that a family brings in their children who are eligible for Medicaid or some other kind of program, but the parents are uninsured. So I think one of the biggest benefits that the safety net provider community sees in this bill is getting insurance to those parents and then getting them into primary care. And of course, if the whole family is insured, it is far more likely that the whole family will have a medical home and that the parents are going to feel also more comfortable getting their kids into care as well. So we really see this as a way to improve the health of the entire family. And that is, I think the point made about the average age of immigrants being younger, that is absolutely what the community health centers see.
Thank you, Robin. Johanna, Fabian Marks?
I just wanted to provide one clarification. I think we might have been a little unclear in the hearing, but the estimates are that there's about 350,000 uninsured individuals in the state altogether. And of those, about 110,000 are estimated to be uninsured, undocumented individuals.
Okay, great. Thank you. I'm glad you reminded me because I was going to say that as well. Delegate Taveras, did you just not put your hand down? Okay, and Delegate Johnson, or did you have another question or comment? Okay,
Pilot error, Madam Chair.
that's okay. Any further discussion on the bill as amended? Okay, seeing none, I am going to take the vote. Delegate Bandari, excuse me. Vinnie DeMarco, you have a comment, contribution?
Thank you, Madam Chair, and the committee for taking this up. And I just want to say we have over 400 faith, community, labor, business, and healthcare organizations from across the state who strongly support this, and we're 100% behind you. Thank you.
Thank you, Vinnie. Okay, Delegate Morgan.
Everyone talking about, thank you, Madam Chair. Everyone talking about how many people support it and the community-based centers, and just judging what Vinnie was just saying, do we have any polling on this at all?
Not that I'm aware of, but if you think you have.
I don't know. I'm
Right.
asking.
Right. No, I
Okay.
mean.
And one final question. How many other states have done this?
For sure, Washington State has done it. California got the waiver, but decided to go another way. But they did have the waiver. And Johanna, do you have information on, I know Illinois had applied for this waiver, but I'm not sure if they got it, and also Connecticut. Is that right?
I know that Washington and Colorado have gotten waivers and implemented coverage expansions using private coverage.
Okay.
And a number of other states have looked at it, and a number of other states have expanded Medicaid.
Right. Yeah. So what other states are doing, they apply for, several are applying for this waiver to extend coverage. And then in the case of California, they decided to do a Medicaid for all program. So they decided they didn't need.
Thank you.
Did I see a hand? Okay, seeing no more hands, I'd like to take the vote. Delegate Bandari,
Yes.
Delegate Gazzoni,
Yes.
Delegate Johnson,
Yes.
Delegate Kaiser,
Yes.
Delegate Kerr,
Yes.
Delegate Kipke,
No.
Delegate Morgan,
No.
Delegate Shalega,
No.
Delegate Taveras,
Yes.
Delegate Woods.
Yes.
Okay, the bill passes, and we will take it to the full committee. Thank you all for your participation in that discussion. And I'd like to move to HB 240, health insurance, cancellation of individual health benefit plans, restriction. This is a departmental bill. Lisa, you want to tell us what the bill does? And there is a proposed amendment to this bill. And let's make sure, okay, I see we have Mr. Cooney on here and Ms. Quay on here. So we have, and the OHG is here. So I think we have the right people in the room. Lisa?
This is a departmental bill that limits the circumstances under which a carrier may terminate an individual health benefit plan. If a carrier receives a premium payment that is less than the net monthly premium due, the carrier must provide written notice of the insufficiency to the policyholder and may not cancel a plan if the deficiency is $10 or less. A carrier may cancel a policy if the policyholder does not make a due net monthly premium payment more than 3 times in a policy year. There is an amendment proposed that specifies the parameters the carrier should use in setting a deficiency threshold rather than putting in statute the $10 or less.
And what does that amendment do?
It sets the other parameters that it says that it would be not more than $20 or greater than 5% of the net monthly premium.
The net monthly premium, okay. So discussion on the amendments. And I'm gonna go with Tricia Swanson.
Thank you, Madam Chair. So it was the league in working with the other carriers that submitted this amendment. And I don't think we're all necessarily mathematicians. So we got confused with the greater than, less than for the 5% threshold. So we actually would ask that we amend the amendment slightly to move the word not up to the clarifying sentence. So it would say carrier may set a deficiency threshold of not more than $20 or not greater than 5%. Because that gets us at that 95% threshold. So it has to be not greater than 5%.
Okay, I'm gonna go to Mary Quay from the Maryland Insurance Administration to give us some feedback on that.
Thank you. I think that we are happy to work with the carriers on that. I found the amendment a little bit confusing in the way it was worded. And what Ms. Swanson just referred to is something I had noticed, and I know there's one carrier that sets 95%. So we are happy to work with them on clarifying the language, because I think the use of the term threshold can also be a bit ambiguous, perhaps, in the way that it is used. So we'd like to clarify that. I think that our bigger concern about the carrier's proposal is whether a percentage of premium that must be paid should be applied to the net premium amount owed after any tax credits are advanced and applied, or to the total premium amount. And we ran some quick numbers, and I can supply them later, but the American Rescue Plan Act extended subsidies so that people at higher income levels can now get them. And so, for example, a 50-year-old in the plan we identified as the most popular, if you take 5% of the total premium, it would be a shortage of $27.14, regardless of what the net amount was. And if it's a 5% of the net premium, then at 200% of the federal poverty level, 5% would be $5.69 as the deficiency amount.
Okay.
So that seems to be the crux of the disagreement, but we're happy to work with them on working out how the amendment can be worded most effectively.
Okay. Matt Celentano.
Thank you, Madam Chair. I think that this is the first time we've heard that threshold, the word threshold, is an issue. And we, in the amendments that we sent over, we just tried to align with the federal guidance. And the CMS has already opined through the federally facilitated marketplaces. And obviously, we're not an FFM, we are a state-based marketplace, but we wanted to align with the federal guidance, which says that we interpret a reasonable threshold to be one based on a percentage of the enrollee responsible portion of the overall premium. So we're just trying to align with federal guidance here.
Mary, do you have a response to that? Or
So
David?
the federal guidance, my understanding is that it is 95% of the net payment, and that is not exactly what's on the table here. We did send amended language to Matt in response to his suggested amendment, and he said that they would not be available to discuss it, but we did try to tweak the language to make it more clear. But we're aware of the federal guidance, but the commissioner's view and our view is that going based on the total premium makes more sense here.
Okay.
So I've had multiple discussions about this bill, too many discussions about the bill. So I wouldn't say that we haven't had discussions about it. And I will say says nothing about net premium in the federal guidance. It exactly, I mean, I'm quoting it. It says, we interpret a reasonable threshold to be based on a percentage of the enrollee responsible portion of the overall premium. There is nothing about threshold in the federal guidance.
Okay, Johanna? Gotta speak up, gotta speak up.
Yeah, can you hear me?
Nope.
Oh, sorry.
Okay. And now you're on mute.
Can you hear me now?
Yes, we can. Thank you.
Okay, sorry about that. So I just wanted to add in some context for the net versus total premium conversation that based on our most recent analysis of our 2024 open enrollment enrollees, we have 36,000 individuals who have a premium after subsidies of $10 or less and 14,000 that have a premium of $1 or less. So if we're talking about 5% of their premium after subsidies, we're talking about between 5 and 50 cents, which is, sort of gets to the point of a dollar amount being something that may make more sense in, alignment with what the MIA was sharing.
Okay. Delegate Tavares?
Hi, I'm sorry that I'm not a lawyer, so I'm not understanding this conversation, frankly. So, well, is the issue the use of the word threshold? Is the use of the word net? Is the use of the word net monthly premium? What's the problem we're trying to solve here? And at the end of the day, what's the bottom line on the cost on the pocketbook of a person per month? I'm just trying to.
Okay, so this bill came from the Maryland Insurance Administration, so I'm going to go to Mary to talk about why the bill is before us and what we're trying to solve.
I'm happy to try to address that. So on the exchange, you can qualify for tax credits based on your household income, and those tax credits can be applied in advance to your premium. And these are generally referred to as subsidies. So depending on your household income, and there are other factors that come into play, but for you personally, it depends on your household income. And those subsidies or tax credits can reduce your premium, as Johanna said, for a large number of people to under $10 a month, depending on the policy you choose, et cetera. And it can certainly reduce your premium quite a bit. And so when we talk about net premium, what we're talking about is, are we talking about the full amount of the premium that CareFirst or United or whoever the carrier is will receive, which might be, say, $500 a month. But you as an individual may get tax credits, so you're only paying $50 a month. So the net premium that we're talking about here is the $50 a month instead of the $500 a month. Does that help?
You see?
Incredibly. Thank you.
Matt, you want to follow up?
Thank you, Madam Chair. I just want to go back to the baseline on this bill, just for the good of the subcommittee. The carrier's position is that we're happy to work on language that would get to a policy that's more uniform, and that reflects the amendments that we sort of sent over. But at the very basic level, we don't think we really need a policy. The carriers are not going to cancel folks because they owe a couple of pennies here and there. It makes absolutely no financial sense for the carriers to do so, especially in these products where they're heavily subsidized. Canceling a beneficiary because they might owe 19 cents when they're going to sacrifice $1,000 from the federal government in subsidy would be foolish financially on the carrier's portion of the program. Now, yes, the carriers had different approaches and different policies, and we thought that we sent over a fairly reasonable approach to make sure that there is a policy that's captured. We also have been told that there is going to be guidance coming from the federal government soon that would make this whole discussion moot. But what we are talking about here is a policy, a bill to address what we have been told as 3 complaints in 2 years. 3 complaints. And of those 3 complaints, we actually tracked down one of them, which was in a carrier's product where the person owed way more than the threshold we're talking about, like $100 type situation. So we don't think this is a problem. We don't think that we really need to have legislation move forward. But if the committee's desire is to do so, we think that what the carriers have offered is a more than a reasonable approach. And more so, if we had had a chance to talk about this fall, I think we might have been able to be aligned. But now we're on day, 34? And all our hair is on fire, right? And we're all running around. And I just wanted to make sure that everybody knew the context. So thank you for the opportunity. I appreciate it.
Thank you, Matt. So Mary, can you address the what Matt just said in terms of the level of concern around cancellations for folks who are paying these extremely low premiums?
Well, I think one thing to keep in mind is many complaints never make it to the MIA, even when they have a notice that gives the person our address. And this type of cancellation would not. I think we look at our file and interpret the information differently than Matt does about the one complaint. But we can look at that again. We're happy to look at that. I think, though, the thing that gives us the greatest concern is, first, at least one carrier has no policy to keep people on. And we want, at the very least, for carriers to have a meaningful policy so that people are not terminated over small amounts. And the reason for that is because to buy an individual policy, you have to either be in an open enrollment period, which occurs at the end of the year for coverage to take effect the next January 1st, or you have to have a triggering event for a special enrollment period, which means a life event like, you get divorced from your spouse who is providing coverage. Mm-hmm. And because people are not able to say, okay, well, I let that policy lapse, but now I have my money together, I'll go buy a new policy. They have to wait until the next January 1st to get a new policy. And that is a tremendous harm for people. They are open to, so we have seen instances where people have fallen prey to producers who are selling products improperly. And once they get out of the ecosystem of the exchange, they are far more vulnerable to that type of approach.
Okay. So I guess I heard 2 things, and then I'm going to go to Delegate Bandari and Matt Celentano. So a primary concern is that one carrier does not have a policy. So this bill would meet that requirement, right? It would say you have to have a policy. And that what the carriers have recommended here sets a threshold that, it's not that far away from your $27. The issue is net versus monthly, or net versus gross, right? So I think that's where we're wrestling here. Delegate Bandari.
Madam Chair, Matt can go first.
Oh, okay.
You might answer my question.
Thank you, Matt.
Delegate Bandari, I'd love you to go first. I think I don't want to beat a dead horse. I think that it's been articulated a couple of times, and why the carriers came in as FWA at the hearing is that we recognize that there is a desire from the MIA to have a policy. And I think we are in agreement if that's the way this committee wants to move forward, we would be happy to work on a policy. And I think that what we offered is reasonable and tracks with what the federal government's guidance is. And I think that's about all I have to say. So thank you very much.
Delegate Bandari?
Yeah, just Madam Chair, just a clarifying question. This is very simple bills, right? If a person owes, what is the threshold we are discussing here, Matt?
The recommendation of the carriers is not more than $20 or greater than 5% of the net monthly premium, what the individual pays.
So will that be more than $20, $10, $15, Matt?
It just depends, Delegate Bondari, and it really depends on what the level of subsidy that the consumer is reaching. And depending, if you have no subsidy, it's going to be a higher number. And then this either or language reflects what we think is a reasonable amount. But nobody, like I said before, nobody is going to be canceling anybody because they owe pennies. It makes no financial sense for the carrier.
So last question, Matt, based on your research, how many folks were cancel their coverage without warning them and giving them a chance to pay the small amount they owe, like let's say $10? Do we have any research?
Delegate Bondari, nobody is canceled without notice. There are multiple attempts to reach out to folks to try to recover the premium that they might owe to a carrier. So that does not happen. As to the MIA, say we were told that there has been 3 complaints in 2 or 3 years in this case for somebody being canceled because of a small amount of money. But this is not a widespread problem. This is not something that we encounter. And like I said, if you are if there's a possibility you're going to be canceled, you are going to be notified multiple times by the carriers.
Okay. All right. Delegate Tavares? Okay.
Thank you, Madam Chair. I just have a quick question. Well, I don't know how quick it is, but what are we talking on for these tax credits and the subsidies that folks are receiving? What's the household income that we're talking about here? Because at the end of the day, for a lot of us, $20 doesn't seem like a lot. Okay, and that's great, thank God. But for some people it is, especially when you don't have income coming in. So that's the question of the day, right? So what is it? What's the income that we're subsidizing?
So I'm going to go to Johanna. Can you give us you gave us the 36,000 who have a premium of $10 and then 14,000 with a premium of less than $1 per month. Can you give us the family income ranges for those 2 numbers?
I don't have that at the tip of my fingers. That will depend on your family size. So if you have a larger family, you can have a higher income and still qualify for high subsidies. But the most highly subsidized individuals would generally be those who are below 150 or 200% of the federal poverty level, which for an individual, I think would be something like around $30,000, and for a family of 4, something around maybe $50,000. I can double check that and put those exact numbers in the chat right now.
That'll be fine.
Yeah. Okay, I'm gonna take Tricia Swanson and then I'm gonna make an executive decision here. Tricia?
I don't want to speak incorrectly because Johanna gave different numbers, but when I looked up the advanced premium tax credit, which is that federal subsidy, it was $50,000 for a single person and $120,000 for a family of 4. So anything below that can access the federal subsidy tax credit. But Johanna, if you come up with, if that's incorrect, I apologize. But in my own kind of research, that's what I had found.
Okay, so we've had a pretty rigorous discussion on what the outstanding issues are. I heard both the carriers and MIA say that they're willing to work on it additionally. So what I'd like to do is hold this bill until next Tuesday, and next Tuesday is it. So And I hope that we can meet before next Tuesday and try to resolve these two outstanding issues. Okay? Any further comments for the good of the order relative to our work?
Motion to adjourn.
And do I have a second on that? Okay, it's been moved and seconded that we adjourn. Thank you all very much for your participation. Have a good afternoon.
Bye-bye, everybody.
Bye-bye.